So when we're talking about esophageal cancer, we are looking at, of course, cancer abnormal cells that have or are growing due to several factors. Esophageal cancer is one of the commonest. It's one of the top 5 cancers. There's also studies ongoing with meat. Of course, meat has been red meat has been directly linked.
You have touched meat again. Welcome to yet another episode of Health Quest by Betty. And today we are privileged to have a nutritionist with us in studio who will help us to understand matters food when it comes to managing your condition. I do not want to let the cat out of the bag, so please stay on and just listen to what he has to say. Asante sana.
Thank you
for coming to Health Quest by Betty.
Good
we
to
really
see you
appreciate
too,
your
Betty.
presence.
Yeah,
Asante. So could you kindly just introduce yourself to the audience, to the listeners, tell them who you are and what you do.
Great. To the audience, my name is Okinda. My background is in nutrition, specialized in nutrition and cancer. So that is my background, and I'm also a research officer. So currently I'm involved in research, especially area of cancer. Apart from that, I also do private practice. I run a consultancy called NutriQuest for nutrition. And again, we've been partnering with you on so many projects. Yeah,
Thank you.
I also do a lecture at Nutrition and Dietetics Academy, where I lecture nutrition and cancer.
Wow. Quite a lot of things. You know, I know most of you have been thinking, this nutritionist, their work is just to tell us about what to eat and what not to eat. But as you have heard today, there is more to it. There is research, there is training, there is teaching, and so much more. And of course, even practice of nutrition in management of cancer. Today, I would like us to talk about esophageal cancer. And this is close to my heart because, again, so many people have asked about it. And it seems to be very common. Is that something that you would resonate with? Would you say, yes, it is common? And if it is common, what are the numbers? What are we seeing?
Okay. Yeah, true. As you've said, esophageal cancer is one of the commonest. It's one of the top 5 cancer in Kenya.
Top 5?
Top 5, yes. Looking at statistics, we have quite a number of them coming up. I might not be able to have the current statistics because the figures keep changing. But in the last global cancer statistics, it's one of the top 5 most rated cancer, both in incidences, that is the new cases, and also in mortality. So it is a cancer of concern. And again, looking at now the risk factors being so much hidden, and looking that the awareness is not as much as we are looking at breast cancer, cervical cancer, and maybe prostate cancer. And even the screening modalities, which are not so far been so much enhanced. So it is a cancer that maybe it's so hidden in a way. So you find it is only recognized at the full-blown capacity.
Wait, just hold it up there. So let's go back a bit. It is a cancer of concern. Maybe the listeners and people who are watching would just like to understand. What is esophageal cancer?
Oh, okay.
You're probably using big words that they don't understand.
That they don't understand. Basically, so if you look at the human anatomical structure, we have a structure called esophagus. So this is just a pathway where the food pass. Digest in terms of digestion, it doesn't have any specific function. So it's just like a pipe that the food's passed by. But it plays a key role because at the junction towards the stomach, there's what we call a valve where it closes and opens to food to go through. So esophageal cancer basically is a tumor, kind of cancer that originates from the esophagus itself.
So we're talking about, this is my mouth.
Yes.
I put food inside.
Yes.
Then there is that pipe, the food pipe.
Yes.
But when it gets just before it opens into the stomach, that is the problem area that we're talking about.
Exactly.
Okay.
So that is the problem area. So it is quite a long pipe that connects the stomach to the mouth in a simple way. So I've said digestically it doesn't have any known functions, but that kind of pathway. Again, what it also helps is, you see, when food is moving, it provides what we call peristalsis, the easy movement of food from the stomach, from the mouth going to the stomach. So it expands and contracts.
So it is what is helping the food to move down to get to where it is required in the stomach.
In the stomach.
So you can't just swallow.
No. You see, now when the food you've taken, let's say solid food, for instance, it has to go through the process of what we call churning. Yeah, that means it is being kind of molded into the simplest form. So for that easier passage, it has to go through the muscles that contract and relax. And so the function of esophagus mainly plays that. Of course, there could be other hidden functions, but majorly, it's just like a pathway between the stomach and also the mouth.
Okay.
So when we're talking about esophageal cancer, we are looking at, of course, cancer abnormal cells that have or are growing due to several factors, which are most of the time unknown. But we find on the normal genetic morphology, you find that there are other conditions, what we call carcinogens, which if exposed to, they of course affect the normal genetic pathway of normal cells. So when that occurs, you find the abnormal cells start growing. And some of the characteristics of these abnormal cells is that when they grow, they don't have what we call a growth inhibition capacity. So they continue to grow and get even into when they come into contact with other normal cells, they continue to grow deeper. Okay?
So basically what you're trying to say is that whenever we're talking about cancer, we're talking about a cell which is just growing out of hand. It cannot be stopped by anyone.
And it cannot die.
And it cannot die.
Yes, unfortunately. So it will continue to grow because normal cells have...
That is sad news.
Yeah, of course, that's sad news. Basically, what is causing it not to die? Of course, there are several factors involved. What they do, they also mimic the characteristics of a normal cell. So with that in place, you find that sometimes you might not realize how bad they are. So they don't die. Normal cells have some duration, like say red blood cells. They have like 120 days.
So every 3 months.
Every 3 months they die and new ones are formed. Cancer cells, on the other hand, do not have that capacity. So they don't have what we call apoptosis, so they don't die. And that's one of the key challenge why cancer has become very hard to treat, because again, they keep on mutating into new cells. Yeah, so as the other cancers, or esophageal cancers, cells also play that same role.
Wow. If you guys didn't know what apoptosis is, now you have been told. All right? So cell death. I actually, as you started and you said this is a cancer of concern, and I was just thinking, do you see it more in a particular group or in a particular area? Is there something that is making us be at risk of esophageal cancer? Is there a group that is more affected than the other? What do you think?
Yes. Statistically looking at the numbers, it's more predominant in male compared to female. And this is because of course, the lifestyle changes of male and the risk factors that are involved. One of the common risk factors that has been studied and confirmed is smoking. So you find looking at the smoking patterns between female and male, of course, male gender has a high affinity of smoking. So because the effect of nicotine, which affects the what we call the mucosal lining of the esophagus, that is esophagus being the pipe, it's protected by a mucus layer, just like the normal gastrointestinal tract. So the nicotine in tobacco...
Actually, you should tell them, anybody who's eaten matumbo, the tribe, from the cow or whichever animal, if you look at it, it has this mucus-like...
Exactly.
Yes, so that is what
so actually that is the explanation. Yeah, so this mucous membrane, its role is to protect the integrity of the esophagus and maybe gastrointestinal tract. So what smoking does, it has a component called nicotine. This nicotine has ability to destroy that mucous membrane, exposing it now to other what we call now carcinogens. So one of these carcinogens could be maybe you've heard about H. pylori, which is one of the bacteria which has been known to cause gastric cancer and ulcers. Yeah, it also exposes it to hot products, like now if those who are known to take hot tea. So you see now you have an esophagus which is opened up, like the defense is not there, and you're taking hot products, so definitely inflammation starts at that point.
You want us to take cold tea?
Not really, not really per se.
Or what is your level of hot?
Okay. Okay.
The one which comes straight from the sufuria, or What's your level of hot?
All right, so the hotness degree differs from individual to individual. There are those people who, what I can call hot is not hot, but again, we are looking at the extreme temperatures that is beyond the normal temperatures. Especially those people who are staying in cold areas. You find many of times, like in Mount Kenya region, there are seasons where it is extremely cold. And when you walk around, you go to the hotels, you find many people are taking tea, hot tea, okay? Just to make sure that they have they keep warm. So the extent of hotness definitely depends on individual. But what we are saying is that just from the cooking or agent, definitely you take it that way without helping it to cool off. That is also kind of, and remember, it's not like the hot tea causes esophageal cancer.
Okay.
What we are looking into, it could be a risk factor, but it can also be now, it can act after already the risk factors have destroyed the mucus lining. Remember, we are looking at the integrity of the mucus lining.
Okay.
So once it has been affected, then therefore you expect that the hot tea will now start corroding
the area.
Exactly.
So we are exposing the area to more harm.
So causing inflammation. And I was speaking of Helicobacteria H. pylori, yes, which I know many people right now is one of the common struggles they have. They even mastered their over-the-counter medications just to try
Tell me about that.
Yeah.
Yes.
You might have people just now, they know that they already have. They go to the chemist, you find that they need amoxil. Which other drug is this that they use commonly? I'm just trying to get it
Actually, what I see people doing is everybody now is buying the H. pylori kits.
Exactly.
And unfortunately, we are doing this without the help of the doctors, without the help of the professionals.
Yes.
Yeah.
Because again, the standard treatment of H. pylori should be 21 to 28 days. After that, and then maybe it has not gone away, then you need to start investigating for other things. For instance, that is where we've already had stomach cancers coming in, because many people have been on treatment for long of H. pylori, yet what we are dealing with is something else, a tumor, or maybe overproduction of hydrochloric acid in the stomach.
So are you trying to say that if today I am diagnosed with H. pylori and I'm given medication, after the 21 or the 28 days,
yes, I
do not recover from it, which is about 3 to 4 weeks, thereabout.
Yeah.
If I do not recover from it and I need another kit, is that a cause for concern? Is it something that should worry me?
Of course, yes, because of course what doctors will do, they already expose you to another test just to check. And when we talk about H. pylori, it's just basically a bacteria we're dealing with here. But remember, if you're talking about gastric ulcer or duodenal ulcer, it's a combination of so many things. So H. pylori is one of them. And then we also have the medications that will help to reduce the stomach acid. And then, of course, we try to also, so we have antibiotic combined, we have PPIs, proton pumps inhibitors, which are now basically the medications that try to reduce the production of HCl acid. So if you've completed the dosage for the 21 days or to 28 days, then you need to go for another retest, of course, for H. pylori itself. Or it is advised that the best way is to do what you call endoscopy, just to check the lining of the stomach. Because again, you could be doing with H. pylori bacteria which has been treated, but still there is an overproduction, or there's a tumor, there's a wound that needs to be sorted out. Yeah. So when we come back to the esophageal cancer, that's exactly what happens. So when the esophagus is exposed, the H. pylori takes that advantage. It thrives in a acidic medium. And then when we have reflux basically we are talking about you've eaten and then the food is coming up from the stomach. Of course, could be due to the integrity of the valves that I was talking about. If it is compromised, you find the food coming up to the esophagus. And then now it provides that acidic media for the H. pylori bacteria. So smoking is one of the risk factors. We have those who chew mirror, cat is another. So I know this will not go well with many people, but again, it is one of the most studied, and to confirm that yes, because the continuous chewing of cat and mirror has been shown to reduce the integrity of the esophagus.
Is it because it increases inflammation, or the fact that it has maybe some chemical in it that will
it is something
that?
Yeah, most of it has a chemical itself that has ability to affect the integrity of the esophagus. Yes, yes. Latest study have confirmed that even the mursik, the milk that we take.
No way.
Yeah, sure.
No.
Yeah, there's a paper that was a study that have been done in those part of the areas that have confirmed the direct linkage of esophageal cancer and the use of mursik. So it is something that, again, it's of concern, considering these are things that people relate with. They have taken them for many years, and I know it might be controversial, me bringing it here, because people, they have been taking mursik for long.
Exactly, because, you know, people have sworn by it, and actually probably, as we go and dig into that paper, just to try and see, was it from a particular area? Is there something else that could have aggravated it? Or compared to the communities that do not take that milk, if there's a problem, so that we don't land into any trouble by the way.
Yeah. So it was a study that has been done. I think when I was going through now different studies in Kenya locally, and I bump into that. But again, as I'm saying, I don't want to really make it that it is a confirmed thing. But again, researchers are still ongoing. But the ones that have already been found is the content of mursik has been seen to highly acidic actually. So that can really have a factor on it. We have alcohol consumption. I know this is a topic that is quite controversial to me saying it, because looking at the majority of Kenyans and those who consume, I want to make a clarity so that I'm not taken out of context.
Yes.
The products I'm mentioning, they have health beneficial like mursik. Partly it has probiotic and everything.
Yes, yes, it does.
But we are looking at the long-term exposure. Even smoking itself. Somebody will say that, okay, I've just started smoking this few months. Am I exposed? Now smoking has been proven. It doesn't matter how long you are exposed to. But again, all these products, the prolonged use. Yeah. So
there's no safe limit, for example.
Exactly. Yeah. So we need just to be careful on how long are we exposed to them. Yeah, because if you are not exposed to it for long, or even the quantity you are taking is not so much, then definitely the risk might go lower, because again, it takes a lot of exposure to break the integrity of the GIT. Yeah. So as I've said, one, for esophageal cancer, gender-based, we have male predominant compared to female, of course, of the lifestyle changes and some of the risk factors, which is smoking, alcohol use. There's aspect of mirror, and there are also the aspect of autoimmune disorders, where just the body of cells start fighting its own cell. We have some tumors of unknown origin. It could be there's just something going on in your body, and then it manifests itself along the esophagus. Yeah.
Quite interesting. And just as I'm thinking, are there any dietary habits, apart from, I know you've mentioned the hot tea, or hot beverages. Let me not use tea. There are people who might come for me. So hot beverages. Yeah. And then you've mentioned alcohol or overconsumption of acidic foods. Is there anything in terms of dietary habits that could also expose us? And maybe you can mix this with dietary and lifestyle issues. All right. Yes.
So, of course, the dietary habits play a bigger role in disease causing, not only for esophageal cancer, but overall health. For instance, obesity has been studied to be linked with so many health-related problems.
So you want all of us to be thin?
No, of course, you and me, Betty, you know how the standard body composition that we are supposed to have, based on your height, your age, and of course your weight. So obesity being one of the key factor. So there is no direct link, or I can say, between obesity and esophageal cancer, but it plays a key role. Remember, when you're obese, you have accumulation of fat within your stomach. You've heard about the outpouching of the stomach, where now the stomach now pass through the opening in the valves. So that again pushes the stomach content to the esophagus. That really exposes you to it. Okay.
And maybe one thing that you probably have to explain to the audience is that whenever digestion is happening, there's so much acid production.
Yes.
And probably that's the reason why we do not really advocate for food to keep pushing up when it's supposed to stay in the stomach. Yes.
Yes, this needs to be well understood. What really happens is that there are foods we eat, especially proteins, that involves acid for it to be broken. Actually, the enzymes in the stomach they are acid specific, so they have to lie on the acid pH for them to function effectively, like the amylase enzymes and all that. So you find when you eat, there has to be overproduction of hydrochloric acid, which is also helping the churning. It also helps in breaking the small bonds of the food. So there will be so much of acid component within that period of you've eaten and the time the digestion is complete. So if you find a scenario where now either the people who really overfeed at one go, they take too much that the stomach capacity cannot hold within the same time. So
but I've been told people just need to eat until you feel like you're full.
All right, there's aspect of satiety. There's a way you can achieve satiety level of, especially now when you maybe take high fiber diet, so you'll feel more full than doing more. Okay. And sometimes it's advised, some people they take a little bit of water before they eat, but I don't want really to advocate for that, because indigestion really comes when that happens. But it's something that some people who are on weight control program, they might take water before their actual food for them to add like a small space to occupy that. So obesity can be one of the lifestyle changes that can be linked with, of course, esophageal cancer. We could also be looking at those people who skip meals or maybe have one meal a day. Yeah, because again,
you have arrived at that topic.
Yes, you find you have acid component in your stomach, and there is no food that can help in digestion. So what this acid, it has a pathway of coming up. Reflux is common. That's why even those people who have gastric ulcers, we advocate for them to take small frequent meals, so at least there is something in the stomach.
But maybe somebody is actually deciding, I'm going to have one meal a day, because I know if I have 2-3 meals in a day, I'll actually overfeed, as you have rightly said. You shouldn't eat too much. So maybe I'm thinking, you know what, let me just eat once in a day so that I reduce the amount of food that I can actually consume.
You know, people need to understand the science of how the body works. So if you take a 1 meal a day, as other people do, most people do that, of course, those who are in weight control program, what the body does, the body will automatically know that Betty usually takes 1 meal a day. So, and Betty needs to survive. Remember, 60% of what we eat is consumed by the brain, and during the day you are active. So what the body will do, the much you've given it, it will give you what you need to do for what you call basal metabolic rate to help you function normally, but it will store the rest. Okay? So this storage is assumption that you'll not be eating frequently for it to have for energy, and you need to work.
Saving for rainy days, just in case you don't eat.
Yes.
The body is okay.
Exactly. So that is more of the risk why taking 1 meal a day, it has, okay, of course, there are those people who practice intermittent fasting, and again, it needs to be under the professionals to guide them. But again, if you just intentionally start that, just know, if you consume so much at one go, your body will definitely be storing for future use, because the assumption is you will not have enough.
Okay.
And now when we want to control our weight, we need to give body small, so it compensates with breaking down what is stored. Yes. So
obesity.
Those skipping of meals. Yeah.
Staying long hours without food.
And of course, the aspect of indigestion, overfeeding, again, the one that we were speaking about. The food takes so much in your the normal digestion should take at least 4 hours. Then now the food takes longer in your stomach. That means you are so much exposed to HCl, hydrochloric acid, in the stomach. So that could be some of the risk factors. And of course, consumption of high acidic foods, as we've known that what we are looking into is the integrity of the esophagus itself. So foods which are highly acidic has also a component of bringing you a problem. Yeah. So
which foods are this?
Of course, we are looking at maybe fruits which are like pineapple, which you consume extra. Of course, they have higher benefit like vitamin C, which are very beneficial for being an antioxidant, all that. But now the overconsumption, so we have fruits which are mostly acidic. We have green leafy vegetables like spinach and kales, which are also acidic. So I'm not saying you don't do them, but excessive,
do not overconsume.
Overconsumption will expose you to that. There is also studies ongoing with meat. Of course, meat has been red meat has been directly linked.
You have touched meat again. do you know why that is of concern to me? Because now people are actually moving out of the normal diet as we know it, and most people are saying, you know what, I want a carnivorous diet because apparently I've been told that is what will help me lose weight, and that is what will make me, you know, not be overweight or obese.
Okay.
So what are you saying? We stop eating the meat, or
not really? Of course, the benefits of meat outweighs even the risk itself. What we are looking into is the preparation methods that we have for meat. For example, now in Kenya we have nyama choma, how they are prepared. Ideally, the ideal way of preparing nyama choma, which has been recommended, it should not come in direct contact with the heat.
So how do you make it?
Actually, it should be steamed. No, it should be like the heat should be outside. But again, looking at the practice that we have, we expose meat into a higher temperature. Yeah, then it goes beyond the normal temperature that you need.
Do you understand how nyama choma is sweet?
I know. I'm a lover of it anyway. But now we are not looking, because you see, my aim here is not to try to take people away from what they love, because that'll be wrong. Yeah, that's why I'm very cautious in using some words. So the key word here is limitation.
Okay.
Yeah, because if we now start advising people to avoid, then we are going to make error in helping these people. So if somebody, limitation means if somebody is a daily consumer, then what if they now can do maybe 3 times a week in alternate days? Yeah, and again, that is number one, limitation. Number two is the amount that you consume at a given go.
So I can't sit down and just take 1 kilogram of nyama choma and do it every single day.
Exactly. So they are what we call recommended dietary allowance for these foods. So you should be within your recommended dietary allowance, because now if you go over is what can cause a challenge. Yes, anything that is over and under will have a health impact.
A health impact. Thank you so much for that. Now, I go to, you've explained to us clearly what it is, what esophageal cancer is, how it comes about, what are the risk factors, and what are some of the lifestyle and dietary habits that we can actually be practicing so that we ensure that our risk goes down and we do not get this disease. However, what if I've already been diagnosed? Does it have staging? And if there's staging, how does nutrition, information, and practice change from each stage to another?
Great. So we need to understand how cancer management works. So the definitive diagnosis of cancer, we usually use what we call the biopsy. So where we take a tissue and then it's taken to the lab just to the pathologist will be able to look at it and look if it is cancerous or not. So if it has been confirmed that this is an esophageal cancer we're dealing with, so basically you can do an endoscopy, then during that point you take a tissue for lab test. After you've confirmed that indeed it is cancerous, of course some pathology will do the staging based on that, but others we will do staging using radiological means. So for instance, we can do staging using CT scan or PET scan. So basically we are looking at the abdomen CT scan and chest CT scan, basically to look at the extent of spread as it spread to other organs, because that will play a bigger role in treatment modalities. So why I'm taking you through this process is now to see where nutrition will come in at each and every stage. So let's take a scenario of a patient who has already been confirmed by biopsy, has confirmed, has come positive for esophageal cancer. We go for scans, which are maybe CT scan and maybe chest X-ray, as tell us maybe it's stage. Now staging, we have different stages. We have of course stage 1 up to stage 4, and in between we have different sub stages. So for patients who are already maybe early stage, that may be stage 1, mainly for esophageal cancer, the main concern that this patient have is what we call dysphagia. which is now the difficulty in swallowing.
What did you call it?
Dysphagia.
Okay.
Yeah. Yeah. So that aspect of difficulty in swallowing comes in different stages. So they have up to stage 1 to 4. So for instance, you find stage 1, you'll take food normally, though you'll feel mild pain, but you can take both solid and liquid food, a little bit comfort, but you'll feel discomfort. Stage 2 is a scenario where now you start feeling challenges with taking solid food, so you have to have it either semi-elemental, so it becomes so smooth, so it doesn't bring you problem. Of course, when we add, but liquid pass normally. So for stage 3, it's now where now you have to do the blended kind of food, because again the soft or mashed cannot pass.
Cannot now go through.
Yes, yeah. Then for stage 4, we at least complete dysphagia, where now even the blended food cannot pass, and even the liquid food cannot pass. We can have just a small amount of it passing through. So for esophageal cancer, because we are talking about tumor that is going to be embedded within the esophagus, so it's going to cause that what we call dysphagia, and that dysphagia is what is going to determine the treatment modality. So for early stage esophageal cancer, you find that the dysphagia is not prominent, and of course now you need to help the patient know how much they can take. Usually for cancer patients, we advocate if you can do 60 to 70% of your total dietary requirement, you are good. Then maybe the remaining you can do the supplementation. So if, for instance, a patient is at the earliest stage, then these are patients you can assist them modify their diet, okay, to meet their overall nutritional requirement. Number 2, another important factor we need to consider is the treatment modality this patient is going to have. Of course, for early stage disease, the treatment can either be surgical, that is removal of the tumor itself. This can come in different ways. I know my colleague has able to explain this. So one, it can come what we call neoadjuvant therapy, where now either you give a chemotherapy before surgical procedure, depending on the size of the tumor, or you give a radiotherapy before surgical. This is that's why we say cancer treatment is mostly a multidisciplinary approach. Yeah. So if, for instance, this patient is at early stage and they only require surgical procedure, then as a nutritionist, what we need to do, there's something we call ERAS protocol that we follow. So in full, ERAS protocol is just enhanced recovery after surgery. So it's just an abbreviation for that. Yeah,
he's making our viewers look like
surprised that they are in medical
we do not
school.
know anything, or we're in medical school. But anyway, thank you for that.
I want to simplify it a bit. So basically, what ERAS protocol guides is that you find many patients become wasted before surgery because of being fasted for long. You know, the surgeons, anesthesia will love to patient not to take anything orally in preparation for theater, because of course the impact of anesthesia. Yes. But now ERAS protocol
and maybe probably so that just in passing, why do we do that? You don't eat anything before surgery.
All right. The assumption is that when you are going for surgery, your stomach should be empty, so that you don't have aspiration. Yeah. So because now when there's food in your stomach and you are anesthesia, it means that even the brain has shut down. So food, when it is in stomach, it can come out and cause pneumothorax issue, aspiration pneumonia, which is quite common.
So you do not want this food to go to any other organ?
Yes.
So the best way is just don't have it.
Don't have it.
Yeah.
All right. But now the practice have changed. That's why ERAS protocol really comes in handy. Because right now, it is advised that you can feed a patient even solid foods even 6 hours before they go to theater.
Okay.
Yeah. Then 2 hours before they go to theater, you can give them what we call clear liquid diet.
Okay.
Yeah. For instance, a clear example of a clear liquid diet could be, the glucose. You can just put it in a normal water and the patient takes.
Okay.
Yeah. So we call it even carbohydrate shot. So the reason why this is important is because it helps in fast recovery after surgery. Because we find many patients who have undergone surgery, they take longer in the hospital.
Yes.
Yeah. Because of either they are recovering, the wound healing process takes time. So for patients with esophageal cancer, if they are undergoing surgical procedure, ERAS protocol will help them. So this is a early plan before they go to surgery. It's a multidisciplinary approach where now nutritionists interact with the surgeon and anesthesia and know exactly when this patient will go to theater, and then we start preparing them early Because the challenge we are having is that if the patient already is having depletion before surgery, after surgery they'll take longer to heal, and they stay longer in the hospital, and that's why even the hospital bills have gone high.
Plus the high rates of infection.
Exactly.
Yes.
Even hospital-acquired infections come in handy for that. So ERAS protocol ensure that you know the specific time the patient will go to theater, so you are able to plan backwards and now know which nutrients do you need to push. Of course, at that point, we need to have a balanced nitrogen, what we call nitrogen balance, become normal. Because when somebody is sick, we find that the body starts breaking down the stored component, mostly the protein, and for energy, because they are not able to eat normally because of loss of appetite. So if that patient before surgical, you are able to bring them up to speed to have what we call a balanced nitrogen balance, where now the protein intake versus the protein catabolism is at 0. You have a normal balance. That is the first thing that you do. So when this patient goes to theater, they'll already have storage post-theater to help them in early recovery. And then ERAS protocol also help us after this patient has left theater and they're back, how long do we take before we initiate feeding? Because, because that also plays a key role. You find many patients being put on IV fluids for longer, which are nutritionally inadequate. And this has led to slow wound healing, for example. So for management of esophageal cancer, just to summarize so that I don't take much of the time, so if it is surgical, we consider ERAS protocol. And again, also you need to, as I've explained, surgical can come in different way, where depending on the size of the tumor, the surgeon will say, can we do radiotherapy first before I go in? Because maybe the tumor is embedded in some critical organs which are not visible during surgical.
So you want it to be shrunk first of all?
Exactly. So if the patient is going for radiation therapy, the role of nutritionist is try to see the side effect of radiotherapy. And counteract them. So one of them is what we call mucositis. It's just the inflammation of the mucous membrane. Remember the mucous membrane we were talking about?
Yes.
It gets inflamed because of radiations.
Yes.
And this causes sores, either in the mouth, or it can cause sores in the gastrointestinal tract. So usually the advice is that if the patient is stable enough, we do what we call prophylactic peg tube. We insert a tube early before they go for radiation therapy, because we anticipate when they go for therapy, radiation therapy, they'll have difficulty in swallowing. Yes. So when they have a tube, it's easy to feed them, all right, with a blended product. So you ensure that that patient doesn't lose weight.
And now in the tube, maybe just for the benefit of those who are watching, for the tube, where are we inserting the tube?
All right, so we have different areas we insert. Of course, we insert it at the stomach level. So stomach has different stages, I can say layers. We have the upper part and the lower part. So usually we can do it at the upper part if the stomach is functioning normally, what we call gastrostomy tube. And sometimes there are some tubes that are inserted at the upper part of the stomach or the small intestine, what we call jejunum, especially for patients who have problem in digestion, but they can absorb the normal. So
you're bypassing everything else and just going straight to the stomach.
Exactly.
So that we're looking at absorption and not really the digestion of the food.
So your main area is just on absorption, but not digestion, because maybe the stomach has issues, especially for stomach cancers. Or if the tumor itself have grown from the esophagus and have gotten into the upper part of the stomach, where mostly digestion takes place. Yes. So that is also another place. So we usually do the gastrostomy tube. We can do jejunostomy tube. Of course, nasogastric tube we can't do because now we have a tumor within the esophagus, so we can't pass the tube from the nose.
So that nasogastric is the one you pass the tube through the nose.
Through the nose. Yes. So those ones cannot apply at that given moment because we want to bypass the esophagus. So if the patient is going for radiation, those are their side effects. They experience issue with nausea and vomiting. They also experience what we call they start feeling some metals in their mouth. They also experience what we call xerostomia, which is the salivary reduction goes low. We know saliva plays a big role in digestion.
Wait, so they will not have saliva? Or
they will have, but because of the impact of radiation, it affects the salivary gland, which is responsible for production of saliva. And you know, saliva is the first part in which the salivary
Yes,
amylase digestion starts from that
and
point.
even just to make this food soft, really.
Exactly, the churning of food and all that. So patients who have undergone radiation therapy, those are some of the things they experience. So what nutrition does is to make sure that this is well explained to the patient early, and then we come with a counteracting measure. If they are feeling nausea, what is the measure? Which usually is most frequent meals at a given frequency. They try to, the foods that smell to them, you try to reduce them. You can also advise them to, when the food is being prepared in a house which is poorly ventilated, they can still be out, so that they don't have those impact of the food, smelling that smell of the food. So if it is chemotherapy, of course, so I'm talking about now neoadjuvant. This is before surgery. So if it is chemo, also because chemo also will help shrink it also, the side effects is more or less the same. They'll experience vomiting, they'll experience nausea, some also experience challenges with the chewing, so oral thrush and all that. So all that is what you need to assess and do and support those patients. Now, if they are already on chemotherapy, and then now we are looking at the early stages. So we are looking at advanced stages, means that the disease has spread to most organs. The treatment modality is usually chemotherapy, because now targeted therapy might not be helpful because the cancer cells have already spread even to the other organs which are healthy. So in that case, most treatment is the chemotherapy. So when that is going to happen, again, you need to make sure that you support this patient at early. If supplementation will come in, you are able to help. So nutrition play a key role at every stage and every treatment. Yes.
Wow, that is so well explained. And now I'm just thinking, this patient is at home. They have probably started treatment on chemo. What are some, maybe, what are some of the practical aspects that you would tell the carer for this patient on what to provide? Because sometimes when somebody is diagnosed with cancer, they're told, no, you can't eat this, you can't eat this, you can't eat this. And as you say, one of the issues is wasting of patients who are suffering from cancer. So does that also happen in esophageal cancer? And if it does, what are some of the practical ways in which at home we can be able to mitigate that?
Exactly. So in cancer, the wasting part, we term it cancer cachexia, and esophageal cancer is one of the most known cancer with cancer cachexia. So basically, cancer cachexia is a wasting disease. That's why if you see cancer patients, you find they're so much wasted. And of course, that wasting is a progressive kind of stages, and it can be caused by different things. The first most common thing is when we have tumor itself. The tumor can produce what we call the tumor markers. The side effect of the tumor itself, what it releases, the chemicals, is one that can have impact on the brain, affect the feeding. It can have impact on the muscles. It can have impact on the liver. It can have impact on fat metabolism. So all these, we have what we call tumor necrosis factor. These are just chemicals that the tumor itself is releasing. This can cause cancer cachexia. The treatment we've talked about, the surgical treatment, the radiation therapy, the chemotherapy, all that can have impact on cancer cachexia. We have the aspect of now limitation of diet. Like now, many people try to limit cancer patients from eating. For me, I said if it's already stage 4 disease, don't limit that patient. Give them everything. Yes, whatever they can take, let them take. And of course, the knowledge is a bigger issue, because if a relative has a patient who has maybe esophageal cancer and they are not able to be taken through the steps, it becomes a challenge. So if I'm to assist a relative who is at home with a cancer patient, the first thing I need to look into is this patient able to swallow?
Okay.
Yeah. You remember when we started with the esophageal. If they are able to swallow, how much? What's
the quantity?
Yes, the quantity that can go and which type. So if they are able to swallow, let's say maybe soft diet, then we can mash that. So it's more dietary modification. If that's not the case, that we have a total blockage of the esophagus, then basically that patient will be having a gastrostomy tube. Yeah. So in gastrostomy tube basically means that the food that we are going to prepare in the kitchen we are going to blend it and then give it via the gastrostomy tube. Now, what should we give? The first, we have, a long time ago, people used to talk about balanced diet. Of course, nowadays it has really changed. We have what we call food groups. So in Kenya, we have close to 7 types of food groups because they each provide different nutrients. So for example, we have cereal and cereal product. So that provides energy for the patient. We have meat and meat product, which will be good for proteins and high biological value proteins. We have egg product, we have chicken, we have green leafy vegetables, all that at a go. So if it is advised that at least patients should take at least 5 to 7 of those food groups in a day. So basically this means that you'll have enough carbohydrate, you'll have enough protein for the patient, enough fat, enough microvitamins to give. So food preparation will play a key role. You don't overcook and you don't undercook again. Remember also there's something that next time when you call me here, we'll talk about, is called neutropenic diet. It's quite common for cancer patients. Yeah, so this is also a very important topic that we'll have time to discuss in other series. Yes. So you don't overcook because you'll try to waste the nutrients. And again, if you undercooking, and let's say cancer patients have low neutrophils, so neutropenic diet definitely is a diet which is really a poorly cooked product can come in there, in that part of it. So you need to provide at least 5 to 7 types of these food groups. The mode of feeding, of course, if it is gastrostomy tube, you'll have to blend and give. Sometimes we have a challenge of mixing everything together and giving because of nutrient interactions that occur. So if it is good, you can give one at a time. And again, when we are giving using a gastrostomy tube, we have aspect of malabsorption, where now the patient start diarrheaing, and you might not tell which specific food has caused that to occur. So that's why it's advisable to give one at a time. So if they are diarrheaing, you'll definitely identify. You'll be able to pick which type of food. So with a gastrostomy tube, you are sorted. You can that patient can feed as a normal patient because you know the only thing you need to do is to modify it, which is through blending. But ideally, you are going to give exactly as a normal person. Of course, now with cancer, you have to go more because again of the disease that you are dealing with. So that's basically, so it's a meal plan that needs to be planned from maybe Monday to Sunday, 5 feeds a day. If you can manage to afford the supplements, it's the better because again, it's going to narrow the gap of the nutrient deficit that cannot be met by the kitchen diet. Because again, as far as we are saying, the blended feeds are okay, but they are not nutritionally adequate.
Okay.
Yes.
So what are we doing? What are the nutritionists doing outside there to make sure this information is with people, so that again you do not we do not speak of things that people are not aware of? Is there any efforts to try and teach the public?
Yes. So quite right now I can say we have a quite enhanced awareness coming up. The challenge we've had is that you find people being jack of all trades. For me, yeah, for me that's what I can say. Being jack of all trades means that you can solve all the problems. For me, the entry level for my nutrition was just the normal, the basic general nutrition
practice. Yes.
Yeah, then of course I went back to school and do specialization now. So I only focus for cancer patients. Of course, it doesn't mean I can't care for other patients, but now my interest, my first priority. Exactly. Yes, so with that in mind, I have adequate knowledge to assist specifically cancer patients. So now we have nutritionists who are doing very well in their different areas. You are doing so well in the diabetes space, and if you bring me here to talk diabetes, I'll definitely not do well in that space. Yes. So indeed, nutritionists are really going out there really to create awareness. But now the messaging, the package of the messaging, it's what now we need to work into, because we can't speak generally. But we can't speak generally. Of course, we agree that patient care is individualized. Yes. But we need to package the message so well. The conversation of take more vegetables, take more fruit nowadays has been passed.
You have to specify what you mean by more.
What is this more?
Yes.
Yeah. So we have to go deep and look at numbers. The numbers is much important. How much calorie do we require How do we break it down into proteins? How do we break it down into carbohydrate? These are conversations now we need to start having. The next conversation we need to start having is now at the general public, the aspect of having food measurement tools in our kitchen. Yeah.
We just eat. You look at the plate.
Yeah.
You determine how hungry you are. And there you go.
Exactly.
Full plates.
Yeah. So
you don't care about it.
You don't care about it. So measuring cups needs to be introduced into our kitchen. And in European countries, this is a normal practice.
And even the food scales, by the way.
Exactly.
I'm just wondering how many of us have food scales at home to just weigh your food. You're going to eat your ugali, you're cutting a slice, putting it on a food scale, food weighing scale. When I say food scale, they think it's something different. So food weighing scale, you're putting it on a scale and then you decide, this is the size of the ugali I'm going to eat and for these reasons. Or I need to eat sukuma wiki, this is the amount I've been given, put it on the scale, weigh it and eat it.
Yes.
Maybe that's how we should be doing.
Exactly, that's the better practice. Actually, that's more accurate, you know, because now when we go that direction, you know, the challenge we are having with Kenyans is that they are too busy for the day. But again, we need also to quantify their work. So then when they get into kitchen, they just want something that they take very fast, and that's well done. But when we bring the measuring cups in the kitchen, it will mean now we know exactly what I'm taking is what exactly I require.
Yes.
And to your surprise, you'll find that we are under eating, basically in one aspect. Because again, if you look at the micronutrients that we need to consume as per our recommended dietary allowance and what we are getting, the numbers are very low.
They are not matching.
Yes.
Very well said. And actually, I think next time when we call you up, we will want you to help us understand how much do we need, when do we need it, and for which group of people, and probably just break it down so that we can finally start selling food skills.
Exactly. We need to. Yesterday, I was in Bangati and I happened to meet old friends and we were discussing just anemia in children. And then we sat down to practically calculate. You know, the Kenyan statistic shows that at least 54% of Kenyan children are anemic. But now we were trying to look at how do we narrow this gap. So we sat down to do the calculation just to see what we are giving based on the diet.
Is it sufficient?
My goodness.
Or not?
For instance, spinach has been known to be high in iron.
In iron, yes.
Yes. So if you are to give your baby who is a 6 months, yesterday in our calculation, we noticed that you need to give close to even 10 kg, 10,000 of course kg of spinach to meet their recommended dietary allowance based on the calculations.
I will not comment on that.
We
will keep it for the next discussion.
Yes,
but
yes.
Even now, as we conclude on this nutrition in management of esophageal disease, is it a myth or is it a fact? Cancer feeds on sugar, and therefore we shouldn't take sugar for as long as you have the diagnosis of cancer. Of cancer.
All right. So it's a very controversial answer that I want to give. But now we need to understand what sugar we are talking about.
Okay.
Now we have the table sugar that we are adding to our tea and all that. And then we have glucose, the blood sugar. All right. So after getting that difference, it becomes easy.
Okay.
Now, when we talk about cancer cells feeding on sugar, what we are talking about, some people take it literally, that is the normal table sugar. But people need to understand, whichever food you are taking, the form in which the body converted is to blood glucose sugar. And this is what the body utilized. So what happens is that the cancer cells, just as normal cells, they mostly rely deeply on the glucose, which is the blood sugar for their survival. So what we are doing is that we need to control, especially now I need also to be very cautious in this statement. For early stages of disease, you need to be very cautious on overfeeding on carbohydrates. But now for late stages or advanced stages, this conversation doesn't apply because we need this patient to take as much as they can get. So at early phase, you need to control the amount of glucose you are giving because again, they support the growth of cancer cells if you overfeed. Okay? So, and that's why sometimes currently the conversation is going about ketogenic diet and also cancer because when you expose a patient to ketogenic diet, it means that they have ketones as the end product, which the cancer cells right now cannot utilize, cannot be able to feed on. But now the body cells are able to utilize the ketones. At the beginning, they struggle a bit, but as time goes by, it becomes a normal use. So to give you if it is true or false, if we are talking about the table sugar, that's false.
Okay.
Yeah, because definitely even if you take table sugar, it will be converted to blood
glucose.
Exactly.
Yes.
So somebody will try to avoid taking sugar from the tea, but they overconsume on carbohydrate and on starches.
So complicated,
So,
right?
Yeah. So they are doing minus actually. So at early stages of disease, we need to be very cautious on the amount that we give, especially the carbohydrate. So we need to give what the body requires so we don't have excesses. But now for the late stage disease, then this conversation that is surfaced, because again, already the reversibility of cancer is not there. Yeah. Yeah. So I can say that it is a myth when we are considering a table sugar. But it could be a fact when now we are looking at the blood glucose, when we give it in excess, because that is what the cancer cells use.
And based on the stage of the cancer.
Based on the stage of the cancer.
Wow. The food debate, the discussion about diet and management of disease is one that can never be complete. And I am sure so many of us already have questions about what is it that we need to eat, and maybe probably even expand it to the other types of cancers or to other diseases where nutrition plays a key role. They say you are what you eat. I hope you enjoyed this podcast, and I hope you enjoyed this episode. And thank you so much,
thank you, Betty,
Kennedy, for coming and just sharing with our audience what it is that we can do in terms of dietary management of esophageal cancer.
Yes.
Thank you so much, and that is all we had for today. Until next time, it is bye-bye from us.